Great. So we have started now. I just give a couple of seconds for people to join in. Yeah, that's great. Okay, so good morning, good afternoon, good evening, everyone. Welcome and thank you for joining us today. Welcome to CDEP seminar series on global health. My name is Erta Kalanji and I'll be moderating this webinar today. We are having a discussion on AMR surveillance in Africa, and we're very honored to have with us speakers that are working hard to bring some insights and quantify the burden that AMR has in the region. So I'd like to welcome Dr. Pascale Ondoa, Director of Science and New Initiatives at the African Society for Laboratory Medicine, Dr. Yewande Alimi, AMR and One Health Program Coordinator at Africa Centers for Disease Control and Prevention, Deepak Batra, Head of Public Health and Government Solutions in the Middle East and Africa for IQVIA, and Dr. Geetanjali Kapoor, Fellow at CDEP. So we'll open the session today with a brief introduction by Dr. Ramanan Laxminarayan, Director at CDEP. So I don't know, Ramanan is connected? Yes.
Yes. Hi, everyone. It's a real pleasure to be here. And, let me start by saying that, it's the 10th year of CDEP and AMR is one of the core areas in which we work. And one of the things that we do that we're most proud of is really this work that we do on AMR in Africa. CDEP has had a long engagement with AMR in Africa. We started the Global Antibiotic Resistance Partnership back in 2009 to take this the question of AMR to many countries and to have them address how important AMR really was. But this continuation of this in the context of the Fleming Fund, where the project that will be described now is a great effort to be able to bring shed light on the burden of AMR in Africa, something that we have very little understanding of. And because we don't have an understanding of AMR in Africa, AMR has been deprioritized or is not prioritized in Africa. Now, if we have to set up lab systems to be able to make labs function in a way that there's real-time information, that could take a very long time. In the meantime, efforts to unlock data that already exist in labs and in the gray literature could have a significant impact on informing us about the burden of AMR, which at the end of the day is what we're trying to do. Another related piece of work that we do is use this data also to inform treatment guidelines in Africa. In fact, we do this work with Africa CDC. So there's many aspects of this work that CDEP does on AMR in Africa, which again goes back to where we started with. But I'll hand back now to Erta to open up the panel to discuss what we're doing collectively between ASLM, Africa CDC, IQVIA, CDEP, and a number of other partners. Thank you.
Thank you, Ramanan. Thank you for that. We'll start the session today with some questions. Can anyone hear me? Everybody hear me? I see that there's okay, perfect. That's great. So we'll start with Dr. Pascale Ondoa, and we have some questions about the Fleming Fund, Regional Grant 1, which is one of the initiatives that aims to address this knowledge gap on the AMR burden in several African countries. Could you please give us a brief overview of the work that has been done so far, and if possible, share some of the findings with us and the audience?
Yeah, thank you very much, Erta. So if you allow me, I will share my screen and project some of the slides. So I hope you can see my screen.
Yes, we can.
Yeah, okay, well, thank you. So we are working in that round 2 of the Fleming Fund. We are working with the MAP consortium. This is Mapping AMR and AMU partnership, together with the African CDC, IQVIA, CDEP, INSTEAD, WAHO, and EXA, who were our strategic partners. So very briefly, the goal and expected outcome of the MAP project was really based on the following problem, that the AMR data for large-scale analysis are very scarce in Africa. And the reason is either because the data are not generated or are not reported. So really part of the activity was to understand what is going on. And then there was also an observation at the beginning of this partnership that AMR and AMU data may exist, but they are not exploited. And we know as a fact that a lot of the data is paper-based and therefore is not yet ready to be part of large-scale analysis. And some of our objective was really to digitize all this precious data that is around. So the objective was to collect, digitize and analyze retrospective data on AMR and antimicrobial use and or antimicrobial consumption. So the core of this analysis is, of course, the prevalence and the level of AMR and some observation on antimicrobial use. But while doing so, because the laboratory network is the vehicle to generate AMR data, we had collected a lot of information on the status of the AMR surveillance network in Africa. And that's the piece that I would like to highlight now. So the first question is, how large is the national laboratory network in those countries that you see highlighted here in yellow, where we have been investigating? So this is how a laboratory network looks. It's a pyramidal shape, and we know that at the top, at the reference level, we have the reference testing, then the clinical diagnostic happens at intermediate level, and then you have those laboratories that has really at community that cannot do antibiotic susceptibility testing, and they refer their samples. So we looked at the size of the laboratory network in all those 14 countries, and some of the network are very large. We look at Nigeria, there's more than 30,000 laboratories, and some are very small, but it doesn't mean a lot at this point. What we try to understand is which from those laboratories in the network are designated or are mandated to do bacteriology testing. Then we apply a questionnaire and we try to understand what's going on. So this is a profile of what happened. We started from the 50,000 laboratories in 14 countries, and out of this, the AMR collaborating coordinating committee tells us 665 out of these 50,000 are supposed to do bacteriology testing. And then we apply the questionnaire on those bacteriology laboratories. And at the end, we see that 391 came back with information, and that's the laboratory where we will have the results in the next slides. What we can see is that only few laboratories in the network, so 1.3%, around 1.3%, perform antibiotic susceptibility testing. So all in all, it's quite few laboratories at the level of a country. And we can see that even among those that are supposed to do bacteriology testing from the National Public Health Authority, then 20% of those actually do not do bacteriology testing for various reasons. Now, when we look at the profile of those laboratories, we see out of the one that was selected for the analysis, we see that there were 70 reference labs, 161 at intermediate level, and 108 at district, and 52 were not assigned, which is in itself a problem that a laboratory cannot understand what is its role in the network. Most of those laboratories were coming from our government affiliated, and we could see that 62 of them perform less than 1,000 antibiotic susceptibility testing in the index year of 2018. So in fact, there are few laboratories doing testing, and when they are doing it, there is a very low level of testing being done. So this is a complicated figure, but it shows you how we scored the laboratories, and it shows you how these are the different countries, the 14 countries, how the scores are spread out in a country. And we see really quite a large spread in several countries. And it might tell us that there's a lack of programmatic investment in those laboratories because they are a little bit all over the place in terms of their capacity. And then we see here a tendency where when the network is a little bit smaller, it seems that the capacity overall is a bit higher. So we see that there are laboratories with a high score and low score. What happens with the one with a high score? Most of the time they are at reference level, they are designated to do surveillance, and they are high throughput laboratories. And the one with low scores are of course the one at lower level, they are not designated, and they do not do a lot of antibiotic susceptibility testing. So really one would think that capacity is present at some point at reference level, and what should happen would be that the laboratory with the capacity should pull the one with the low score. So what could be the areas of improvement to strengthen laboratory, the AMR surveillance network? We noticed that improving access to antibiotic susceptibility testing at lower tiers, just like what happens in high-income countries, would be something important. Electronic reporting of results, automation of the testing is also a way forward. And then look at the situation of biosafety cabinets for those laboratories, and advance overall the quality of the testing at all tiers of the network. And of course, for the human resources, increase the number of specialist microbiologists, especially at intermediate tiers. So that's in a nutshell what we found for the laboratory network. Thank you very much.
Thank you very much. Thank you, Pascale, for this very unique insight into the network and their capacity to conduct AST. And as you outlined for us, there are quite a few challenges, but in this context, they also could represent opportunities for improvement. So how do you see that the Fleming Fund regional grant findings could benefit the countries and their partners?
Well, I think, thank you, Erta. So I think that already quite some funding that the Fleming Fund puts in countries and in the regional grant is spot on. And particularly the effort to increase external quality assessments in the countries, making sure that there's some quality of the testing. I think there could be a little bit more effort in terms of improving the number of laboratories that have accreditation and the laboratory that implement quality management systems. That's an area for improvement. And something that I still do not see completely addressed is the research and development that will need to happen so that antibiotic susceptibility testing can be done in simpler way, in more affordable way, also at the clinical level. As long as those data don't come from the clinical side, we will not have a solid surveillance system.
Thank you. Thank you very much for your insights. I think we will continue with Dr. Yewande Alimi. And the first of the two questions is that in the last few years, there has been an increasing number of initiatives to assess AMR burden in Africa, Fleming Fund being one of them. So what do you consider as significant achievements and barriers to the implementation of some of these initiatives? We'd be happy to hear your input on this.
Thanks very much. And you rightly said it. One of the key achievements that we can see on the continent is the increased partner funding to support many of our AMR activities, particularly AMR surveillance. One of them, and like Pascale already presented on, is Fleming Fund regional grant. But that said, Fleming Fund also has other regional grants, two of which Africa CDC, ASLM are leading. Apart from that, we also have the AMR multi-partner trust fund, the likes of the US CDC, World Bank, investing heavily in our countries to support surveillance activities. Beyond that, we're starting to see very high level political commitment. As of 5 years ago, Africa did not have any political commitment towards AMR apart from what we knew at the global level. But last year we had the Africa Common Position, which was endorsed by the African Union heads of state and government. And one of their priorities was to heavily invest in antimicrobial resistance activities and controlling antimicrobial resistance across our member states. Similarly, last year during the World Antimicrobial Awareness Week, we also had the regional directors of the African Union organizations, the regional tripartite organizations, as well as UNEP, make a political commitment to supporting our member states in addressing antimicrobial resistance using a One Health approach. But I think for us, the single greatest achievement that we can highlight is the country's interest and ownership. More and more, we're starting to see more country-led, more country-owned, and more country-funded AMR activities. For us, AMR achievements are what the countries have prioritized as their existing needs. So they're taking, like I'll say, the driver's seat in driving what their own agenda is. And more than ever, we're starting to see good political backing. And it goes without saying that this will ensure that we have sustainable interventions and initiatives. One of the things that, like your question, talking about the challenges. I know Pascale touched a bit on it in her presentation and some of the interventions she has made. There's several challenges that we can highlight for this conversation, but one of the, just a few of them that I would really like to talk about and for us to take a good reflection is, we're seeing sort of a difference in terms of the advancements across sectors. Now we see very good investments, good infrastructure, good testing capacity in the human health sector. But when you compare to the animal health sector, it's completely different. And we know that there's no way for us to fully address antimicrobial resistance without using a One Health approach. And when we talk about the environmental health sector and even the plant health sector, we're definitely missing them in the bigger picture when it comes to AMR surveillance and quantifying the burden across our countries. So beyond that, the question is, so what can we then do when it comes to these challenges? There's several other barriers, like we're not seeing good demand by clinicians for diagnostic testing. COVID, for one, has definitely affected our supply chains for AST. It has also affected our human resources, as we are seeing several of our experts who have been working in the AMR space being pulled into the COVID-19 response. Several countries have highlighted barriers around things like transporting specimens. And I'm sure that Pascale also highlighted that the absence of the standardized protocols and quality assurance criteria definitely gives us very poor AMR data, despite the investments that we are making. So I think some of those are the key barriers that we have experienced when it comes to quantifying AMR data on the continent.
Thank you so much for that. Actually, it's a good time to kind of mention the One Health approach to AMR, because our next question is about that. So the African Union established a task force on antimicrobial resistance in 2018, and it included representation from human, animal, and agriculture sectors. What would you consider as investment priorities to enhance collaboration between these centers? Between these sectors, sorry.
Thanks very much for that. Yes, so the African Union Task Force on AMR, which is the political body and task force of the African Union addressing AMR, like you've rightly said, under the leadership of the African Union Commission. One of the things that we have prioritized, it goes without saying, is we heavily need to invest in physical and human resources. We need infrastructures. We need things in place. We need trained experts to do the testing. We need epidemiologists to understand and analyze the data, but most importantly, we need that connection between data and policy. Means that we might be putting all of this, really nice data together, but what does it mean for the countries? Like, how does it translate to policies and interventions? Beyond that, we heavily need to consider investments around improving laboratory initiatives, not just microbiological, but looking at things like the genomic capacity, the genomic technical capacity and infrastructure to help us produce quality AMR data across and within sectors in our member states. One of the things that we are doing at Africa CDC, you might be aware, is our Africa Genomic Institute, Pathogen Genomic Institute, which really focuses on strengthening the capacity of our member states for genomics and bioinformatics. So one of the things that beyond outbreaks, because that team has really done a fantastic job with COVID-19, as you would know, that now we are able to do genomic analysis for the various variants in the continent. One of the things that we are trying to say is, how can we then get more investment to translate those best practices or those lessons learned into AMR? We also need to, we need investment. One of the things I said, and I'm really passionate about, is how we use our data. Many times we are advocating for countries to start to test, to collect, to analyze data, to submit data to regional platforms such as the Africa CDC, as well as WHO's GLASS initiatives. But many countries keep asking us, so what does this mean? How are they able to translate AMR data to things like developing infection prevention and control SOPs? How is it able to translate to the treatment guidelines? How are they able to develop initiatives that will control AMR in their own country, in their own context? We also need investment. One of our priorities is advocating for increased domestic financing, in addition to external financial support relevant to all sectors. So what we want to see is, we want to start seeing investment, not just in our human health sector. We want to see investment around testing in animal health sectors, as well as food, plant, and environmental testing sites that perform bacteriology. Finally, we really advocate strongly, and you must have seen it from most of the work that we are doing now, for local production, local and context-specific innovations. We really need to invest heavily in innovations across sectors. COVID has clearly shown us that we have the capacity as a continent to locally manufacture PPE, for example, alcohol-based hand drops, which are relevant to infection prevention and control and biosecurity. Similarly, we, as you must know from the work that we are doing at Africa CDC, is also advocating for local productions of vaccines. We want to support countries and invest heavily into research, whereby as a continent, we're looking to develop antimicrobials, particularly antibiotics, addressing things in local or context-specific ways, such as waste management tools, and looking at safe, effective alternatives to antimicrobials. That's one of the things that we are particular about, is exploring safe and effective alternatives to antimicrobials, both in the human sector as well as in the agriculture sector. Over to you.
Yewande, thank you so much for your insights. This has been a very interesting discussion so far, and I can see that there is a lot going on in the chat at the moment. I can see a lot of interaction, so thank you for everybody that has joined us. I'd also like to remind that at the end of the session, we're going to have I would like to remind everyone that at the end of the session, we'll have some time for questions from the audience, so make sure to enter them in the Q&A section of the Zoom platform. And now I would like to ask some questions to Deepak Batra from IQVIA, that is responsible for data collection in some of the projects that CDEP is also involved. And so far we've been talking about surveillance and the capacity to conduct AST, the capacity to basically look at AMR, but data collection is a critical component of surveillance. And for the Fleming Fund project, data collection has taken place at the same time in several countries. And we wanted to know if you could share some of the challenges that you've encountered in the field when it comes to data collection.
Thanks, Batra, and thanks to CDEP team for inviting me, and congratulations, first of all, for your 10 years. If you could allow me, I'll probably pull up a few slides that I have on this topic. Just give me a second. Yeah, so if you would actually see So IQVIA does a lot of data collection, not only for Fleming Fund project, but as you mentioned, for a lot of these things. So we do a lot of data collection, especially when it comes to medicine consumption. And there are challenges when it comes to Africa. In fact, I will not even say Africa, but most of the low middle income countries. I mean, we know that when it comes to these kind of data sources or assets, when it comes to medicine consumption, even labs to be frank, can be clubbed in the same bucket, but data sources are fragmented. There is what we see is that what that leads to is very limited collaboration and intersectoral discourse on data partnerships. There's lack of that in most of the countries. The data governance models are lacking. So every time you get into these discussions, there are challenges related to data sharing agreements, what we can share, where we can take the data. So it almost happens on each and every of this project, and obviously those are challenges which also came when we started Fleming Fund. So, but then once again, I would reiterate that it wasn't unusual, it wasn't anything great, but yeah, I think these are some of the systemic challenges when we talk about data collection, and especially data collection in countries such as Africa or low middle income countries, where we face these challenges of data sources not being standardized. There's a lot of coding and bridging which is required. So what you collect from the field, you actually have to work on that data so much to actually make it ready for analysis and consumption by the policymakers. That takes a lot of effort. A lot of times the data is incomplete as well. So while you will have data for a particular month, but then a particular month would be once again be missing, or for certain commodities would be there and certain commodities would be missing. We once again encountered some of these challenges when we were doing data collection for Fleming Fund as well. And a lot of these, I would say, also stem from the fact that most of the activities when it comes to data collection, especially in Africa and low middle income countries, is still ad hoc, right? We don't do routine data collection. We don't set up mechanisms for data collection. So which once again gets us into a loop on every project that we start, like Fleming Fund when we started, to go through the whole approval processes, ethical concerns. The accuracy of the data is always under the scanner when it comes to these kind of, because once again, you are doing one-time data collection exercises, so there are no validation and checks in place at times. So the participation of private sector, we know that private sector plays a major part when it comes to medicines consumption, when it comes to lab testing, when it comes to AMR as well, but then participation from private sector, we faced this in Fleming Fund as well, was a major challenge. It is difficult to engage them, and you can understand some of this information for them is business. So they are sometimes uncomfortable sharing a lot of this information around how many number of lab tests are they doing, or how many medicines are they selling. On those kind of things, they have their own individual approval processes as well. And a lot of private sector organizations or private sector labs, pharmacies are realizing that this data for them is commercial, right? They are able to make commercial use of this data. So why just provide it free of cost for global health initiatives? So that's one of the challenges that we face. One of the specific challenges that we faced in this Fleming Fund project was also around. So you would have seen when Pascale was presenting that our initial objective was to not only collect data on antimicrobial consumption, but also on the utilization, which actually requires us to link the data to individual patients, which we were not able to do in most of the countries, because obtaining patient level data on medicine consumption or antibiotic consumption does become a big challenge. But yeah, as I was saying, I think the real challenge that, in my perspective, what we see is that to have an effective surveillance mechanism, it cannot be covered by doing these one-time exercises, in my view. I mean, it is a great solution to obviously get some data, as Ramanan was saying, that there's a lot of data which kind of hides below in the lab records or paper records or gray literature, and we are able to extract it. But in a longer term, to improve the data assets that we have, routine data collection is what's needed. Ad hoc or one-time exercises have a lot of challenges. They are subject to sampling errors. They cannot reflect the changes in volume or prices or over time changes that you would want to follow. They are subject to error when it comes to medicines, especially. while estimating the dispensing data at an outlet level is never the same. If you are collecting it one time, you go back to the same outlet or same lab 1 year down the line, the data would look very different. And if you're not collecting it on a routine basis, then you do not have a very uniform baseline. So that is where I think what we have always proposed as IQVIA, and also as someone who has collected data and experienced data collection for last, almost as an organization for the last 5 decades, IQVIA has been doing that. We have always advocated that countries should set up mechanisms for medicine consumption data on a more routine basis. It cannot be a one-time exercise. It cannot be just retrospective data collection. It has to be an ongoing effort, which has to happen on a monthly basis, quarterly basis, or with a regular frequency. And that's what will set up which are databases or data assets which are more uniform in nature, which would provide much more certainty when it comes to results and a much better data quality. And before I close, I mean, so it's not something what we are talking about, which is impossible, right? I mean, so an organization like IQVIA has done that for the last 50 years across all these countries when it comes to prescription data, when it comes to, so it is very much possible. And you would see on this slide that it's not just we are doing it in developed world, but there's a lot of low middle income countries or developing countries where these kind of data assets, routine data assets are set up and these data are collected. And in fact, even in Africa, IQVIA has done that over the last 20 years or so in a lot of countries. There's obviously a lot of missing countries when it comes to Africa. And that's what, once again, we are advocating that to make sure that Africa has these data assets to use from a global health perspective on a regular basis. Global health stakeholders have to come together and also co-invest with private sector organizations to set up these data assets and set up these antimicrobial consumption utilization data assets in these countries. So that's what I would say. There were a lot of challenges, and there are no quick fixes to solving these challenges. In my view, it has to be a longer term solution of setting up these routine data assets. Thank you.
Thank you. Thank you very much. And I really, it's impressive to see the last 2 slides as well, to see how far you are reaching with your activities. And so when it comes to operations in different countries around the world and the, antimicrobial consumption data I'm talking about, how do operations in Africa compare to the rest of the world? Or how do they compare?
Yeah, in fact, that's a good question. I had something on that, and we have been once again. So again, I would say it all comes down to, as I think Yewande was also telling, like political commitment and some sort of a governance model needs to be there when it comes to data. So we work once again, as you would have seen on a couple of other slides. IQVIA does this for a living almost in a lot of countries, a lot of developed countries. And where we see the differences is that the countries have set up a lot of standardized data collection platform, and there is willingness to share. And this willingness to share is mandated in the public sector, and also sometimes there's willingness to share in the private sector as well. For example, in UK, there is a mandate in place for sharing data when it comes to antibiotic consumption. Now, this is something which has been happening. There is a granular level, prescription level data coverage. So they have data when it comes to antimicrobial utilization as well. And I think those are the kind of things which Yewande and Africa CDC are right now leading those efforts, which I'm sure that in time will bear fruit. It's all about having the right kind of political commitment, right kind of governance models, right kind of buy-in for the private sector. You have to incentivize the private sector to share this kind of data. And that is where these kind of things will catch up over time and make sure that even Africa has the kind of data assets, the ones which are already available in a lot of other developed countries. Thank you.
Thank you, Deepak. I'm going to end the slide sharing for you, if that's okay.
Yeah, I've done that. Thank you.
Very good. Thank you very much for a lot of insights into into antimicrobial consumption data collection all over the world. And now we are going to focus a little bit on the last part, I guess, or like, well, I wouldn't say the last part, but one of the later stages, which involves data analysis. And for that, I have a few questions for Dr. Geetanjali Kapoor, who is a fellow at CDEP, who has been leading CDEP's work on the Fleming Fund project. So Geeta, can you hear me? Yeah.
Yes, I can. Thanks, Zita. Yeah.
Okay, perfect. Sorry, just had to double check the connection. Sometimes it's a little bit, no, it's not that good. So when it comes to data analysis, what are some of the issues that you've encountered when you analyze data from such different sources?
Right. So maybe I would like to just share my screen, if that would just, be possible.
Please, thank you.
Yeah. So in fact, that's what we are seeing right now as we are analyzing the data. I'm going to just put this on full screen. Yeah. So this is just a very trying to make it a little interesting to show how we are getting the data from several sources. So you see these couple of buckets I've put here with the different Legos, and just consider that one bucket means one lab. So we are getting data from so many different laboratories, and every lab is pretty unique. Some labs are giving us a lot of data, some are giving us less data in terms of quantity, and even the quality of the data, that is very, very variable, because we know some of the labs are referral, they have more in-house capacity in terms of testing and staff speciality, while the others may not have. So there is a lot of heterogeneity. Apart from that, even, we've not been able to, in Fleming, and I think that's there for most of the projects, we can't sample all the labs, right? We have to go over just a bit out of the entire population of labs. So again, the representativeness is also it has to be considered. So when we get this kind of heterogeneity in the data, and we are trying to then finally find out the AMR estimates, that's our output. How do we harmonize this disaggregated data? That is the most important issue which we have faced. And of course, I'll come to how did we do that. And apart from just harmonization, we've also had challenges in finding out the best way to estimate the confidence intervals around that estimate which we have found out. So these were, a couple of issues which, and you can see on the left-hand side, I've just kind of labeled a few of these issues, which resulted in our having data that needs a lot of harmonization. Also, maybe going a step further, we definitely had to circumvent these issues. So as long as like harmonization was concerned, we followed the best possible evidence, which is also there by CLSI. We had some exclusion criteria, for example, information which was incomplete, it had to be completely excluded and filtered out. And wherever the data points were too little, like you have just about, say, 10 results for a particular bug-drug combination, we couldn't consider it because it would skew the results in the end. So these kinds of inclusion and exclusion criteria have to be considered, and that's what was meant by harmonization of the data. And even when we came to the estimate for the AMR, conventionally, I mean, this is more statistical, but conventionally, the researchers, they use the normal Wilson method, but it's not possible to use that one in our setup, especially when you have such heterogeneous data. So our researchers at CDEP, they developed a different kind of CI estimation method, and Uta, you were one of the researchers for that, along with Dr. Klein and Gilbert. So we developed a different method, which is a more robust way of estimating the CIs around that estimate. So I hope that answers this particular question. Thank you,
Geeta, for sharing this this insight with us. I think, yes, so going on to my second question is that lack of financial support is probably one of the major barriers when it comes to, setting up routine AMR surveillance in countries, which Deepak also touched upon. But are there any feasible interventions, like low-hanging fruits, that can be easier to apply and utilize, that would really help the countries with having an overview of what's going on with AMR in their country, in their region?
Yeah, so of course, I mean, even Yewande had mentioned that, and Dr. Ramanan and Pascale, I think everybody has alluded to the fact that we do need a lot of investments as we are trying to strengthen AMR surveillance, and well, that's a long way to go. But moving maybe to my next slide, I do have some. So this is just to show where does, if you see in the middle over here, AMR surveillance is part of a spectrum of various activities. So maybe we should just first understand, when we say, how do you want to strengthen AMR surveillance? It has to, there are lots of events that happen before that. The patient comes to the hospital, he starts his therapy, the samples go to the lab. Once the results are out, he gets a targeted therapy, that's the stewardship. And then of course, rest of the results, they help in the surveillance and setting up empirical guidelines and other public health interventions. So if we need to strengthen the surveillance, apart from finances, we can also focus on other low-hanging fruits, which of course, as you see here, we need to have a choice of the labs, like which are the labs which you want to target, from where you want to collect the data for AMR surveillance. So in Fleming, we have tried our best to pick up the labs which are most representative. But of course, as Deepak also mentioned, these are one-time exercises. So we need to have this going on. Another area where we can focus on strengthening the surveillance is just skilling up the workforce. Now, this is also a part of the health system strengthening building blocks from the WHO. They also do emphasize that the workforce is a very important building block of the health systems. So that is that undoubtedly is an area which is a low-hanging fruit, and teaching, retrainings, the workforce is really important, especially in the low middle income countries, and just not, that doesn't mean just Africa, even in the other Asian countries. This is also possible with the referral labs. They have this capacity and they can mentor the low level labs. We can get support from the pharma and the biopharma companies, the CSOs and other organizations. They can be involved in these mentoring. Another area where we can strengthen surveillance is, first of all, also set up the surveillance standards. So far, what we are doing in Fleming is we are following the WHO Global Priority Pathogen List. But honestly, I think the best way forward is the region, the country should have its own standards, which are the high priority bacteria and antimicrobials relevant to that particular region. So you do the surveillance especially for those groups of critical pathogens instead of just the global. So we need to also establish that, and that can come from good clinical interactions with physicians and understand the local epidemiology. Information systems, of course, is something which would need investments if you want to make it electronic. But as much as, even with paper-based records, if there is emphasis on good record keeping and being sure that all the essential parameters are filled out, when we get these data collection formats from the labs, and from the pharmacies, we see lots of information missing. So as a result, we have to filter out a lot of information. Unfortunately, this is wasted data. So if within the hospital, and in pharmacies, they ensure that the critical information, just not the lab, but also pertaining to patient's diagnosis and his antimicrobial usage, if we get all that information, it would be such a wealthy piece of information for us to triangulate and to see what are the potential drivers. So these are just ways to strengthen the surveillance. And of course, leadership and governance, I may not go much into detail, but Wendy really spoke in detail about that. And I think Africa is very lucky that way because it has this Africa Union which brings together all the different countries under the One Health umbrella. So yes, we also need to coordinate with the other sectors. So that is another way to strengthen. And I did see a couple of questions around this, how to triangulate it with the One Health other sectors. So that's the way to go. But if you say financing, yes, financing is needed. That's not to say that we don't need financing. Financing would help us in automating the labs, bringing up, more genomic studies, upgrading the paper-based and manual record keeping to electronic. So these are the ways we can actually strengthen. This is basic principles of epidemiology which need to be addressed. That's it from my side on this particular question. Ota?
Thank you very much. Thank you very much, Geeta. That was a very nice slide to end the discussion. But we were not done yet because we have time to answer some questions. And there's one that sort of fits in with what you just mentioned, Geeta. And it's a question on the utilization of point of care or rapid diagnostic testing for AMR in the continent. What is the extent of that? And this question is open to all of the speakers. If any of you could answer that, that'd be great.
Yeah, so I think in terms of point of care, that's just not in Africa. It's all over the world that now there has been a lot of emphasis on POCTs just because it brings up a quick way. It's a way towards diagnostic stewardship and to strengthen that. So you collect the sample faster, you send it quickly for testing, you have results early, and you can follow the targeted therapy. So, but to what extent it is there, it may, Fleming Fund regional grant that we are really discussing, that has not taken this particular objective as part of our study. But I do know that there have been a couple of other programs in Africa which are trying to see the amount and usage of POCTs in the continent. So unfortunately, we cannot give you figures for that, but there are other, because this is a new area. We know that POCTs utilization is not something which used to happen in the past. It was pretty restricted to maybe just typhoid and HIV, but now it's there for even COVID, it's there. So yeah, that needs another study or program to pull out the data for utilization.
Thank you, Geeta. Pascale, did you have any comments?
Yeah, yes, thank you. So whether they are point of care or simple tests to do antibiotic susceptibility testing, I do not think so. I think that there's a gap in research and development in that area. I think probably to diagnose some of the infection, yes. But this really brings an important point that there is now from the WHO what they call the essential diagnostic list, which is supposed to be a tool that will now help countries to kind of regulate or prioritize what kind of diagnostic they have to put at each tier of the laboratory system. And I think that's an opportunity to now look at what is available from a technology point of view and what is useful in a setting that is sophisticated or at a community level to really push towards a technology that can help for the bacteriology testing and AST. Over.
Thank you. The next question is about the connection between lab data and clinical outcome data with regards to AMR. One of our members of the audience is asking if there are any initiatives that connect these two. So lab data and clinical outcome and AMR. I know Deepak mentioned that it was mentioned in the discussion that this was lacking when it comes to the Fleming Fund project.
We did do that. So that was part of the Fleming Fund regional grant. And in fact, it was a very important element of our objective, trying to bring out the clinical profile of the patients as well as their lab profile, triangulate it, and then try to see that when you say this is the resistance rate, also substratified across different kinds of populations. So that was definitely an aim. Of course, this is not a platform where we can reveal the final results. But in general, what we have been seeing is that the information that we have been getting, and we did a retrospective study in Fleming, there is incomplete information on the clinical parameters in most of the countries, but in some of them we have been getting, especially on their diagnosis and on their antimicrobial usage before the samples were sent for testing. So that is going to be some wealthy information for us to finally analyze and present forward. But that's what it is. So the limitations out of our study is that there is no standardized formats existing today in just not Africa, but even LMICs. So that is where we would be giving recommendations that the hospitals, the surveillance teams, they should emphasize that these things are filled out at the clinical level. So we don't have to, go back and collect this data again and again.
So if I may, I can continue with another question.
Yes, please.
One of the audience, one member from the audience is asking if there was any data that was captured during the Fleming Fund Regional 1 project, if there was any data that captured stewardship initiatives. So AMS.
I think in the map consortium, I can't remember that we captured this kind of data, because that was not directly related to the outcome. But Deepak and Geeta, maybe you collect that in other initiatives.
No, you're right.
Yeah. So you're right. It wasn't collected as part of the Fleming Fund grant, but I think there is some part of our eligibility questionnaire does kind of at least hint towards the kind of linkages that are there in the lab data and some of the other data assets, and how are these reported back. So there is some sort of data, but no, there was no comprehensive data collected on the stewardship activities. And as far as I know, there is no real database which exists, or an exhaustive or an comprehensive data collection has been done on these stewardship activities. At least I'm not aware of.
Yeah, I'll agree. I think both what Pascale and Deepak said, we did have a question in our questionnaire, which does say antibiotics prescribed after the sample was collected. So that question was, in a way, trying to find out the Stewardship Act, whether the targeted therapy and de-escalation happened. But we are not getting any information for that. I mean, that the various challenges why the data could not be collected. It may be existing in the records, but it was not collected, and hence it would not be something which we would be able to highlight upon.
Thank you. I have a question that I believe is directed for Yewande, and it's on the ownership and leadership that is needed to achieve some progress with AMR surveillance. And the question is, what about efforts in mobilizing internal resources to support national action plans for surveillance? I think, Yewande, I'm not sure if the connection is very good. I think the screen has frozen, or is it just me?
No, we hear you.
It's frozen.
The screen is frozen. Okay, then we can perhaps attempt a different question. This is what happens when everything is live. Yes. So this was another question, but I don't know if we have the answer for this, but from the AMR and AST data collected in the African continent, is it possible to kind of estimate the proportion of one health type of data? So some data that also includes veterinary and agricultural data.
I mean, one of the starting points, and it was really a decision from the Fleming Fund, realizing that we are collecting historical data, and the One Health initiative started to be implemented. It took a while, so it was agreed and recognized that data from the animal health and the environment were not going to be that many, so that we would focus our attention to that. So we recognize that now, since 2018, a lot of effort have been made, but we consider that there would have not been enough data from the other sector to collect. So that was a collective decision that we took at the beginning. But now it's probably very different. So looking at the proportion of especially animal health data, because there's a lot of laboratories that are really coming to get that capacity, I think it's a lot better now. Now, the real question is, how are those data being used? I think it's not enough just to generate data, but are those data now transformed into actionable report, and what are the public health actions that are being taken on, based on those data? I think that's probably still a gap as far as I can understand.
And just to hold on to that, when it comes to the availability of data, are there any data on the quality of medicines? It's another question. Does this data exist?
But that might be a question for Deepak or for Yewande. Yes.
So no, once again, I'm not sure if there's a data on quality of medicines. I mean, WHO frequently publishes reports, which they do, once again, not through any kind of routine exercises. There is generally data. I mean, so when you say quality, if you're talking about counterfeiting, if you're talking about substandard medicines, there is no data, but there is obviously a lot of evidence, once again, which WHO has published over the last few years. I think there has been a report as well, which obviously points out that it has been the case in a lot of countries, including in Africa, especially when it comes to some of the Western African countries. There have been a lot of cases which are well publicized, well published, but I don't think there is a formal data. Once again, I think the solution to this is implementing technology such as traceability, track and trace. I think these are the technologies which will be able to generate data when it comes to even quality. And just doing one-time random checks and random surveys will provide you evidence that it exists, but it will not give us the routine data to establish these things.
So just a quick one, Deepak. I think, technology will be important to trace that, but I think that's the mean to an end, right? And I think having the mechanisms, the role, the responsibility, the people that are accountable to indeed collect the data and take a decision and sanction when they see no conformities or fraud, I think that is missing. And that's really an issue of the whole governance and coordination, who is doing what. And of course, the technology comes in support, but what we are missing are really that the authorities see what are the problems, and they appoint people to do it with the budgets for them to be allowed to enforce the regulation that is being proposed.
Very true. Yeah.
Thank you so much. And since we are on this topic of data collection, there's one question about WhoNet and how that has impacted AMR data collection, and specifically. They ask what are the challenges with using WhoNet for data collection, AMR data collection?
Yeah, maybe I'll take this one. It was actually very beneficial to use WhoNet as the data collection tool for Fleming Fund. We deliberately decided that we should use WhoNet. We did not want to reinvent the wheel. It's a standardized tool, and it's there in global domain, and it's publicly available. Also, it was an effort, to digitize the data through use of WhoNet. It was indirectly we were building the capacity of the teams which were collecting the data, because they were outsourced, from those particular countries and from IQVIA. So it was also a way to digitize and build local capacity on WhoNet. I think it was. I wouldn't call it challenging, but it was more of a benefit. And we do hope we leave behind that kind of capacity, and the programs can sustain afterwards. I see Dr. John Stelling is also there, and of course we must. I do acknowledge that he's been a great partner to efforts of MAP, and just very, very approachable all times. As our from the Captura side, that's a sister consortium along with MAP under the Fleming Fund. Yeah.
Thank you. And I think we have reached our time limit for today, but we have one more question for you, Yewande. I believe she's back.
Yes. Apologies. I had a bit of a power cut and the Wi-Fi went off. Sorry.
Yes, it happens more often than I would like, the power cuts. I just wanted to ask you this, ask this question about any efforts to support countries with national action plans on AMR surveillance.
Yes, so as a matter of fact, one of our priorities as Africa Union is to support our member states on developing and actually implementing the national action plans. This we have been doing very much in collaboration with the tripartite organization, the regional tripartite on the continent, to support our countries. Our AUIBA, that is the African Interbureau of Animal Resources based in Nairobi, which is the African Union organ that focuses on agriculture and animal health, has actually been supporting a few countries, Somalia and I believe Sudan, in their developing their national action plans. So one of the things that we are really strongly advocating for is beyond just developing national action plans, is working with countries at every point to support priority activities or objectives of their national action plans. So be it infection prevention and control, be it antimicrobial stewardship, be it biosecurity, as well as legislation, which touches a bit on the counterfeit medicines questions that you raised earlier. So those are the things that we are doing to support our member states on that. And I know that recently WHO has put out a costing a tool towards that effect. That is one that we are hoping to support our countries with, because we know that you might develop a plan until you are able to figure out how the money comes in to implement the things that you have stated in your plan, your action plan. That plan is just a plan. So we are working very closely with countries to go beyond just developing those plans, but actually implementing them and tailoring them to their context. Over to you.
Thank you very much. And I see that it's time to wrap up for today, but not without saying thank you first. It was a huge pleasure to have you all here. And I think we've all learned a lot. It's been a very informative session. So thanks again for taking your time. It's everybody is so busy. So, and thank you to everybody for joining in and all your insightful questions. We are going to have another webinar, our 8th one in the 10 webinar series, and that's going to be about the global oxygen crisis in relation to the pandemic. So thank you very much, and wish everybody a good day. Take care. Goodbye.
Thank you.
Thank you.
Thank you.